psychologist. I, for many years, was a behavioral science director at a family medicine residency program outside of Philadelphia, and currently I'm a consultant for health management associates, where one of the things I'm doing is I'm talking with payers and health systems about family caregiving. So I'm going to give you the whirlwind tour, and we may have to skip a couple slides, but let's get on with it. Okay, so it's not advancing the way I want it to, so let me try to advance it this way. Okay, here we go. So I want to give a little bit of an overview of family caregiving in America, and then how, in my opinion, we're at a point in history where there's never been so much interest in family-oriented care, or what I call family-engaged care. And then I want to talk about insurer level, health system level, provider level, and family caregiver level initiatives that are currently going on, which I think are very promising, and which suggests that we are in a new golden age of families and health. So with that as an introduction, let me go on. This is a photograph from 1942 of my father when he graduated from the University of Pennsylvania, and he's at a dance with my grandmother, his mother. And if you could see my grandmother's face, she was glowing because my dad was her oldest son and was really the apple of her eye. And she doted on him throughout his life and was very, very possessive of him. And my dad was a bit of a mama's boy and would, allow her to dote on him. So when he went off to World War II in 1942 and then came back, actually in 1946, he moved back into his parents' house in Queens, New York, where his mother basically waited on him hand and foot for the next decade. And here my dad finally gets his act together, and in 1957 gets married. And there on the right is my mother in her lovely white taffeta dress, and my dad on the left in his snazzy white tuxedo. And there's my grandmother in between them, which is actually where she liked to be in their marriage. So my grandmother and mother were rivals for my dad's attention and affection, and they got along, I would say, okay through most of my dad's life, until at the age of 51, my dad was diagnosed with brain cancer. And at that point, my mother and grandmother began to really fight over who was going to control his care. So even though my mother had the legal right as a spouse to make the medical decisions, my grandmother felt that she had the emotional right because she loved my dad more to make decisions for him. So they fought over where my dad was going to be treated and what treatment he was going to receive. My grandmother read about this experimental treatment for brain cancer in California and wanted my mother to sell our family home in New York and move us to California. But my mother, like all of us, had multiple family roles. She was a wife, but she was also a mother, and as well as a daughter to her own aging parents who lived nearby. And she told my grandmother no. And okay, there's a lot of, if someone could hit mute, that would be good. In any event, my mother and grandmother, basically the relationship completely broke down. And at that point, when my dad died about a year after he was first diagnosed with brain cancer, from that point forward, my mother and grandmother then did not speak again for another 17 years until the day of my wedding. So this is an example of how family adversity, family medical crisis drives family members further apart and compounds the suffering. And that is why I grew up to become a psychologist, working on family caregiving, and medical family therapy issues to help families do a better job with these kinds of medical crises than my own family did. And if you live long enough, you have multiple family caregiving experiences. My mother went on to get remarried, and she had a very nice marriage with my stepfather, Steve. They were living the good life in South Florida for many years in the gated golf course community when my stepfather developed Alzheimer's disease. And my mother was having increasing problems caring for him. So in 2010, my wife and I moved the two of them up from Florida to live near us in Pennsylvania. And then after about a year, my stepfather went into a nursing home. And here is my mother literally spoon feeding my stepfather lunch. She would go 3 or 4 times a week to do that. In a tremendously, a really awful nursing home But my mother, if she could get him to clear that plate, eat everything on that plate, then she would leave there ecstatically happy. And it was always an amazing sight for me to see. And then, unfortunately, after my stepfather died, my mother herself developed dementia, wound up in a nursing home for the last year and a half of her life. And then it was time for me to step up. And I did the best I could, didn't spoon feed her, but did the best I could. And then my mom died of complications of dementia in the year 2017. So none of these stories I'm sharing are uncommon. They're all increasingly common. So we know that right now there are about 40 million Americans who engage in some form of caregiving in the course of a year. And that's a number that's increasing because of demographics. As our population ages, there's a greater prevalence of chronic and serious illnesses for which people need care. And that number is also increasing because of medical advances. So people live longer with heart disease and neurological disease, but they don't live longer whole and self-sufficient. They live longer with functional deficits for which they need care, and that care is primarily coming from family members. Most caregivers, even in this day and age, are women. The men are stepping up. This is not just a baby boomer issue. About a quarter of caregivers are millennials and a quarter are Generation Xers. If you take the 40 million and you boil them down to one caregiver, it's a 49-year-old woman who's still working at least part-time. She's caring for her mom, has been doing so for about 4 years. And she's also caring for maybe adolescent children. And so this is the classic sandwich generation caregiver, being squeezed from the generation above, squeezed from the generation below, and feeling very stressed. That said, when you look at the statistics of people's psychological experiences with caregiving, is very varied. So about a third of caregivers will tell you that they feel highly stressed, and those caregivers are prone to have both medical and psychological sequelae of their caregiving. About half of them say that they're somewhat stressed, and then another smaller amount, an eighth of them, will tell you that they're not at all stressed. And the 16% here are folks who will tell you that they don't even think of themselves as caregivers. They think of themselves as dutiful wives, dutiful daughters, doing what's expected of family members. So my main thesis, and what I present to lots of audiences, is that because of the aging of our population, because of the rise of chronic illnesses, because of the implementation of value-based care, and as a consequence, the emphasis on decreasing hospital readmissions, there has never been such an opportunity to see families as another social determinant of health that has a major impact on how well outpatient treatment plans are implemented and how well we can ultimately decrease ER and hospital utilization and lower healthcare costs. And that, what I would say is that, it's not new for healthcare to think about families. I mean, healthcare is always, to one degree or another, thought about families. But we're entering a time where we need to do so in a much more explicit and formal way. We need to engage and support family members and empower them with using evidence-based, evidence-supported programs and make that experience a normal experience of healthcare. And so for that, we have a long way to go. Just to look at some of the research, and many of you are going to be familiar with this, probably the most important research about the impact of family caregiver intervention, family caregiver support on patients' clinical outcomes is the work of Mary Middleman, the very famous study from 2006, where she used her Alzheimer's caregiver intervention called the NYUCI. It's a six-session intervention, counseling intervention, and support intervention. And by using an intervention with caregivers, she found that she could forestall the nursing home placement of Alzheimer's patients for nearly 2 years. So if you take into account that the average nursing home in today's market costs about $90,000, a nearly 2 year of forestalling of placement means an almost $180,000 public health savings, which is extraordinary for an initial outlay of maybe a couple $1,000s for a family caregiver intervention. So that's the research everybody points to. There have been other research studies which are not as comprehensive, not as compelling. But just to cite them very quickly, David Roth, epidemiologist at Hopkins, has done a series of studies on people post-stroke. And it's found that when there is a family caregiver on the scene, then that the person who has had a stroke is less likely to be hospitalized again, which makes perfect sense. Laura Ray, who's a CFHA member, works out of the VA in Buffalo. She has done research on some of the telephone support groups for caregivers of veterans without dementia, and has found similarly that there's decreased utilization of healthcare on the part of the patients as a result of her telephone support group. And then there is a white paper that was put out by the National Bureau of Economic Research that found, in essence, that when a caregiver is involved, and it's not just with dementia, but with many different disorders of older adults, and the caregiver is trained to detect urinary tract infections, upper respiratory infections, or COPD exacerbations, and bed sores. So, being able to do skin inspections and to sound the early warning when skin is getting red and developing into a sore. That's family involvement. That basic family medical care at home will greatly decrease hospitalizations and decrease Medicaid costs. So these are just some other examples of the way caregiver interventions affect care recipient costs. There's I think a very good study in the book. It's called Family Caregiving: The New Normal. It was a study that was done by Laura Gitlin and Nancy Hodgson in 2015, looking at all caregiver interventions for dementia patients. And I should mention that dementia caregiving is really the main body of work in the caregiving research field. But Nancy and Laura found that overall caregiver interventions unfortunately had a weak to moderate effect, but that the best caregiver interventions, the ones that had the most robust impact, were the ones that were multi-component. There were interventions that included caregiver support, education, training, skill building. That they engaged caregivers very actively in having to demonstrate skills, and rather than just kind of passively reading a website. That they delivered information multiple ways through in-person, direct contact, phone consultation, over the web, via texting, and that when you have these multi-component interventions and you implement them for long periods of time, then that's when you really see the best results, and where you see a decreased rate of nursing home placement of patients. So despite the fact that we don't have all the research findings that I would like us to see, there has been initiatives that have been undertaken in a number of quarters, which I think are very interesting. So on the level of the insurance companies, and I'm impressed that we have someone from Anthem on the call today. I have a feeling Meryl Friedman put him up to this. There was a study that came out in November of 2017 from AARP and my employer, Health Management Associates. There was just a survey of different insurance companies who are providing managed long-term services and supports. These are basically very large, mostly large national Medicaid managed care organizations. And this is just a basic survey, which, here's a link for the survey. And this report has some very interesting, what are essentially experiments that are being done around the country on the part of insurance companies, where they try to figure out ways of empowering and supporting family caregivers to see a return on investment, to ultimately see fewer patient hospitalizations and fewer nursing home placements. So this is not empirical data per se, but this is just a kind of description of what's being done out there. Lots of insurance companies are trying this now because they see this as a promising area. I mentioned MLTSS. There are about half the states in the country now have managed long-term services support. So that means home care and nursing home care, which comprise LTSS, that those are being managed by and those services are primarily paid for in this country by Medicaid. And so Medicaid insurers are taking over those services in various states, including my state of Pennsylvania. And then those insurers are on the hook for keeping costs down, nursing home and home care costs, as well as ultimately hospitalization costs. And so it's because of MLTSS that a lot of insurers are looking at family caregiver supports as a way of lowering costs. But there are also other insurance products. So there's what are called DSNPs, disability, special needs plans, which are a particular form of Medicare, Medicaid insurance that are used with folks who have disability, who have younger ages, and this too is spreading throughout the country and is putting the onus on insurers to keep costs down, and therefore reach out to family caregivers. Okay, can someone put mute on, please? Thank you. And then Medicare Advantage plans also have are spurring they're spreading throughout the country, and they're slowly spurring the increased insurance interest in family caregivers. And there, so just to cite a number of companies, and so the United Healthcare, one of our big national Medicaid providers in many states in this country, put out a white paper in 2017, which I lists. It was their corporate office, their community state office that was putting out a white paper to the local and regional plans around the country with suggestions for ways that they could better support family caregivers. And I think it has some nice ideas in it. I know Anthem has been, committed to improving care for family caregivers, as has Centene. And that the range of services that all these insurers are looking at are having web-based caregiver intervention. United has actually a very nice website along these lines. They have both telephonic and in the case of AmeriHealth, in-home case management. They have respite, and they have they're creating peer support networks to better support caregivers. Again, this is not evidence-based as yet, but these are experiments that the insurance companies are trying around the country in order to lower healthcare costs. So that was the insurance company level. On the health system level, the interest in family caregivers has been a little slower coming. There has been increased prevalence of Medicare ACOs around the country, as well as complex care management programs. And that those two developments have led to some increase in family caregiver supports. And those supports often include normalizing programs for family members by incorporating those supports into the first provider contact with a patient. So rather than a healthcare provider working with a patient, then only later on maybe reaching out to family members, so that it's done on the first day of care. Some health systems are developing care management systems that are specific to family caregivers. They have what are called family caregiver navigators or specialists, and those folks are not working with patients, they're only working with family caregivers. And then more health systems are offering caregiver stress management and education programs. So to cite a few of these, and they tend to fall into certain buckets. So one bucket is palliative care, which as a field is very interested in family caregiving. And to cite two exemplary systems here, Alina in the Midwest and WellMed in Texas and Florida, both have developed interesting and robust family caregiver support programs. I'm very familiar with the WellMed program. I do work on occasion for WellMed, and their program consists of dedicated family caregiver case managers who do an initial social work home visit. They're providing ongoing telephonic education support, and then they have WellMed provides this evidence-based stress management program called Powerful Tools for Caregivers to all its the caregivers in its Texas hospitals systems, and it's doing quite nicely from what I understand. In the area of specifically dementia, Baylor, Scott, and White in Texas has taken some of the evidence-based protocols that are used in the area agencies on aging around the country for dementia caregiving, and that's in particular the REACH protocol, and has been incorporating that into the health system's practices. And that they have found that it lowers the rates of hospital and ER use for both the dementia patient and for the dementia caregiver. And then probably the best example is Dignity Health out in Santa Barbara County in California. They have a health system-wide program, not focusing on any particular population, but all populations, with a specific focus on older adults who are transitioning from the hospital to the home. They have a social worker go out to the home. They offer also a stress management course called Powerful Tools for Caregivers. And then they use community health workers, all of whom are Spanish speaking, for their Spanish speaking community that they serve. So that these are promotores. And the promotores are working specifically with the caregivers, not with the patients, but providing ongoing support, picking up prescriptions for caregivers, accompanying them to doctor's appointments with patients, just offering overall guidance and support. Dignity Health also works very hard to link caregivers that they're working within their sphere of health with community agencies that are dedicated to family caregivers. And what they have found is that this decreases caregiver depression and has decreased both patient hospital and ER utilization. And then let me just talk briefly about providers. So I think we are coming into an age, certainly, or maybe we are already fully landed in this age, where there is a kind of a general feeling of pressure that people have to lower ER and hospital admissions and readmissions. That everyone has gotten the message from their health systems that business as usual, as per 5 years ago, can't go on any longer, and that there seems, in general, within the provider community, to be an increased awareness of the social determinants of health. So, housing, transportation, home and environmental issues, and that also includes family caregivers. And now, as you know, in all the health systems where you work, on all the EMRs, every patient is given a rising risk score. The physicians and other physical health providers all have dashboards, and those dashboards will give them the rising risk scores for each of their patients. And then at least some portion of their compensation is being tied to their performance with handling high-risk patients and keeping them out of the hospital and keeping their costs down. So all of these are factors which ultimately mean that physicians are thinking more about what's going on in the home, how do we keep people at home, and those homes have family members in them oftentimes, and so it puts more impetus here into the system to work with those family members as partners in keeping the patients out of the ER and out of the hospital. I have my own assessment that I do I've presented bits and pieces of this over time. I've kind of consolidated this recently. I mean, all of us here in medical family therapy do assessments that we've learned. The one that I've developed that is specific to caregivers is a seven-point assessment: who's in the family, what's the family history, especially regarding their previous experiences with caregiving, a la John Rowland. But some things that are a little bit different than perhaps we are accustomed to doing. So number 3 here is the caregiver actually willing to provide care? Because that is not always in question. And if so, what are they willing to do, and what are they not willing to do? And for how long are they willing to do those things? Because treatment plans have to be shaped by, to a large degree, by the caregiver's willingness. And people pick and choose as to what they're going to do. And then what are they able to do? What kind of limitations do they have? Limitations of energy, of understanding of patients. And then number 5, are caregivers willing to receive support? Because so many caregivers reject the support that's available to them because they say things like, we're a family that takes care of its own. And using the support that's available causes them guilt. So to avoid guilt, they avoid support, and that can make the best laid plans of insurers and health systems be for naught if the caregivers won't receive the support that we're spending money on to make available. And then the last 2 things I think are going to be more familiar to you. I have my own ideas, something called honoring the mission, about how do we learn the positive meanings and negative meanings that caregivers derive from caregiving. And along those lines, I have my own protocol, which I published years ago in Psychotherapy Networker. The gist of it is asking the question, why do you do what you do for your loved one, to the caregiver, with the idea that we're trying to get at the values that underlie their choice to give care, because we can't have any care plan. Excuse me. We can't have any care plan that's inconsistent with the caregiver's values. So the caregiver's values are such that that accepting help will somehow violate some basic notion, some belief that they have. Then we somehow have to work with that, understand that before we can kind of recommend people go to support groups or take on respite care. And then the last thing in the assessment here is using things like the Zarit Caregiver Burden Inventory to assess caregiver stress and burden. So the final level I'm just going to mention very briefly is family caregivers themselves. So there's lots of information on the web for family caregivers, including things I've written for the AARP website about how caregivers can better work with healthcare professionals, better partner with them, things like that we're all familiar with, arriving at the doctor's office with a list in hand, getting the HIPAA form signed so the patient can, by the patient so the doctor can speak openly with you, and debrief, doing some pre-work before you get to the office visit to use the office visit as efficiently as possible. Along those lines, Jennifer Wolf, an epidemiologist at Johns Hopkins, who does, I think, some of the best research in family caregiving there is. She's come out with several very, very interesting studies in recent years that look at what are the specific things that either promote or prevent caregivers from partnering well with physicians. So she has something called the Same Page Trial. And all of this is a paper and pencil form that the caregiver and care receiver, the patient, are supposed to fill out before the medical visit in order to come up with some consensus about what is the gist of the medical visit today. What is the presenting complaint? What do they want to get out of the medical visit? What's the patient's role? What's the caregiver's role going into the medical visit? And the results have been, with this very simple intervention, that it's led to improved communication with the primary care providers, especially for folks who have mild cognitive impairment, who need a little bit of support from the caregiver, but may not need the caregiver to take over the visit entirely. And the last thing I'll mention, another study by Jennifer Wolf. She looked at the usage of patient and family portals in our EMRs, which could potentially be an excellent way for family caregivers to communicate with the healthcare team and feel supported by the healthcare team. But not surprisingly, what Jennifer Wolf found is that when caregivers giving caregivers and care receivers access to doctor's notes improve the communication with the provider. So if you could actually go in and read the chart note, you got a better idea of what the doctor or nurse practitioner was thinking, and that made you feel, gave you a better sense of what your role was and what was expected. But at the same time, that many health systems, EMR protocols, are not easily accessible by patients' family members. So we have this potential platform by which improved communication can occur, and because of the technical limitations, and I think just a lack of usage by our health systems, that we're not really taking full advantage of this EMR portals. Something for us to think about. So in summary, and I told you I'd stop at 11:40, and it's right at 11:40. On the insurer, health system, provider, and caregiver levels, the trend is, in fact, toward increased engagement and support for family caregivers. And I think that's wonderful, but many, many operational issues remain, and that the only way that we're going to see increased momentum on this is that we have to continue to advocate, and more especially, we have to continue to do the research into the current programs we have, and to demonstrate really conclusively to the insurers, because they're the ones who need to see this, that improving the quality of caregiver support ultimately improves the quality of patient care and decreases healthcare costs. So with that, I would like to stop and take any questions that you have.
So, Barry, thanks. And we can field one or two questions via audio. If anyone has any other questions, you can also use the chat button below. Click on that and type that in, enter it, and Barry can answer some questions from the chat box too. But any general questions or comments from Barry's talk?
Barry, this is Deepu George. I think that since you were in a training program before, in terms of training family medicine residents, what is the general receptivity of physicians in training to consider this, and what's the best way to sort of help them think about, particularly caregivers? Because one of the things that I see residents do here is obviously treat the patient, but the caregiver is often silent or unengaged until probably the behavioral health team gets involved. Are there incentivizing strategies to get physicians to be more curious?
Great question, Deepu. And I would say, I have separate training that I do specifically for physicians on this. So just some very basic things. I mean, I train physicians in being aware that they have an impact on caregiver well-being, and so inquiring about how caregivers are managing, it matters greatly. When caregivers feel acknowledged, that supports them. When caregivers feel ignored and marginalized, that actually does harm. So I talk about physician impact on caregivers, and then I talk about the potential for partnering with caregivers and ways to partner with caregivers to deputize caregivers to observe treatment effects, to implement treatment plans, to provide ongoing follow-up, and that ultimately is in the physician's best interest to partner with the caregivers. Unfortunately, and there's tremendous ambivalence within the medical community about families, and to this day there are many people who feel that involving families is somehow besmirching the sacred physician-patient relationship. And I mean, these are old attitudes, but they die hard. And so I think we have to demonstrate as best we can how vital a caregiver could be in terms of the overall treatment planning. And this is, we have ideal cases for this, right? We, certainly dementia cases, but many other types of chronic and serious illnesses where the caregiver is involved, and is really what makes or breaks the case. So that's what I would say to you, Deepu.
Thank you.
Any other questions?
Yeah, it's Scott Roland. I don't think you mentioned it, but in one of the links you mentioned paying caregivers and the overall reduction in healthcare costs by paying caregivers. In places like the Netherlands, they've been doing that for quite a while, and the cost savings have been proven already over and over. So I was just wondering if you know of anything in the United States.
So within the last few years, there are more states, counties that are certifying family members as home health companions, and are paying them modestly. They pay anywhere between $10 and $14 an hour to actually do the hands-on work and be the caregivers themselves. I haven't seen data in this country, but what I would say is that the caregivers love it, and many of them are signing up for it. Because it's not a great amount of money, but their work is being valued and acknowledged in a way that it wasn't previously. I have also heard, unfortunately, about people abusing this, which you set up any system where there's now a stream of revenue, someone's going to figure out how to abuse it. And so, in the state of Pennsylvania, I have heard those stories. But I think it's a great idea, and I see, especially given the current dearth of home health aides nationally, and that's in part tied to the immigration debate. There is many markets that lack certified nurses aides. State legislatures and agencies are inclined to give the money to family members and let them try it, since they can't. Agencies can't hire professionals to do this. So I think we only see more of this.
Any other questions, comments?
I had one other one. I don't know how much, I mean, what's your knowledge about taking in more global costs of caregiving in terms of like things like lost work time, things like that?
So what, you know, when
different than what's the cost of the healthcare system one way or the other?
I mean, there are people who crunch those numbers and come up with estimates, and it's so I think that the latest estimate that I've seen along those lines is $450 billion a year. I think this comes from either United Hospital Fund in New York or from AARP or maybe both. But that's an estimate based on if you placed an hourly rate for every hour that the caregiver gives to a loved one, and taking into account other things such as absenteeism, presenteeism, all those things put together. You're talking about an enormous sum of money, which, $450 billion dwarfs the Medicaid or Medicare budgets. And that, there are people who put stock in that number of people who don't. Clearly, family caregivers provide support in healthcare of enormous value that we have, as a country, been very slow to recognize and to even to empower, support. We've just sort of taken it for granted that family members are going to step up and take care of one another because that's what they're supposed to do.
Thanks.
Barry, we got a question from Matt, and I don't know if he had to leave a little bit early. He said, "Very fantastic information. Are there any states or countries that serve as examples of good elderly care?"
I mean, I can't speak to elderly care. I can talk about supportive family caregivers. So the Scandinavian countries have great social services in all regards, do a great job of supporting family caregivers. They give family caregivers, basically full salaries for the work that they're doing, more compensating them at a higher rate than we're currently compensating them in this country. So they do a better job. Probably England does a better job than we do. Things are getting better. I mean, I've been in this field for over 25 years. They're much better now than they were in the past, but we have a long way to go. And I think that there's a growing political constituency of baby boomers in particular who want these services and are putting pressure on their legislators to ensure that these services are funded. One of the things that's happened is the National Family Caregiver Support Program has slowly seen its budget allotment rise over the last decade, even as many other social services have been cut. So I think slowly but surely our federal and state governments are kind of getting the hang of this and are supporting caregivers more for the same reasons everybody else is. They want to lower healthcare costs, especially with the rapidly aging population. I just was at a meeting yesterday in Washington, D.C., where it was a meeting of 5 states, all of whom wanted to improve their family caregiver support policies as a way of lowering healthcare costs. So that there's interest in many quarters in doing this right now.
That's great. We have probably time for one more question or comment or thought from the audience.
So Patrick Coakley, could I put you on the spot? You're still muted.
You have to unmute it. Press the microphone.
Sorry, guys. Yeah, of course, Barry. What can I do for you?
So, I mentioned Anthem, and I know Meryl Friedman, and I don't know if you work for her.
I do.
But okay, there you go. So, can you tell us a little bit about what your company, your insurance company, is doing for caregivers?
Of course. Actually, there's some very exciting things that are happening. One of the things that Anthem does is we support the National Advisory Board on creating better health outcomes for older adults and individuals with disabilities. And as a part of that board, Sandy Markwood from the National Area Agencies for Aging, Yanira Cruz from the National Hispanic Coalition on Aging and Kathy Burrow from Parent to Parent have actually just completed a blog post for us talking about the importance of family caregiving And they've hit on a lot of the points, Barry, that you included, talking specifically about the median age of caregivers, understanding that they're going to have multiple responsibilities, but then also talking about we have this large influx of other communities that are also providing caregiving. You mentioned, the large numbers of the Latin community that are participating or acting as caregivers. We're also seeing, as we see LGBT communities age, we're seeing sort of chosen family, or as Armistead Maupin used to say, logical family versus biological family, also take up caregiver responsibilities. So we are also using that information to think, how can we be more agile to support as many of caregivers as possible, even if they don't have sort of the historical, I'm taking care of my father, I'm taking care of my brother sort of roles. And like you said, we're learning that the more supports that we give, and the more sort of background and tools and resources we offer, not only is the better outcome for them, but we're also talking about a population that will likely be in need of caregiving services themselves. So you have people caring for individuals who have disabilities now, who will in turn become people with disabilities themselves. So that's been really, really great. You hit all the nails on the head. I think it's also interesting, and one of the things that Sandy especially would press us on is that, we need to move away from this idea that caregiving is not going to be an outcome for all of us, and start making it a norm and a discussion that we all have as a part of our medical care and our thoughts about aging. And when we do that, sort of going in open eyes, as you suggested, we'll definitely meet some